welcome to our podcast today. This is Talking with Pods, and we are podiatrists. So how convenient is that Pods are doing a podcast. Today's topic is peripheral neuropathy. 3 million people are diagnosed with peripheral neuropathy every year. And it's a problem that can last for years, if not a lifetime. So you can imagine how many people in America have peripheral neuropathy. So it's a very common problem. It affects mostly the foot. It can sometimes affect the hand, but it's really mostly the foot. So foot doctors commonly treat ingrown toenails, as everyone knows. But what people might not know is that I, for example, and we can ask the other doctors, I see peripheral neuropathy probably 3 times a day in my office, and maybe an ingrown toenail 1 time a day. So basically, in my practice, it's about 3 to 1 toenail problem to peripheral neuropathy problem. So it's very common. My name is Dr. Christina Jensen. I'm from New York, and I'm joined today with Dr. Michelle Kurlansky in Maine and Dr. Melody Stouter in Pennsylvania. Thank you so much, you guys, for joining me today. We're all very busy practitioners. Our time is very valuable, and I really appreciate, you guys spending the time to get together. And I thought it'd be interesting if we had people from different areas, Maine, New York to Pennsylvania, talking about the same problem, because we might have different perspectives on this. And I thought that this could benefit viewers to hear different perspectives on it. Yeah. First, I'll just simply define peripheral neuropathy. It's pain or a dysfunction in a nerve outside of the central nervous system, which is your brain and spinal cord. It's nerve damage, and it usually affects the foot, I guess, because the foot is the furthest away and is more susceptible to things that cause peripheral neuropathy. The most common cause is diabetes, which is high sugar levels in the blood. Usually a type 2 diabetic actually is the one that has peripheral neuropathy. And it can be caused by injuries or infections or exposure to toxins. So the first question I'd like to ask you guys is, if someone thinks they have these problems, how is peripheral neuropathy diagnosed? Do they go to the general doctor? Do they go to the neurologist? Do they go to the podiatrist? And what would these doctors do to diagnose the problem? Why don't you start, Dr. Kurlansky, and tell us what you think, how peripheral neuropathy is diagnosed?
I think it may be 50-50. Like, some people come from their primary care providers already knowing that they have peripheral neuropathy. There's a really high incidence of diabetes here in Maine. So a lot of people already know that they have, some numbness, tingling sensations to their feet. And then there's the other folks that come in that have had diabetes for a while, and I've been seeing them. And then I start to ask about these things, or they ask if I can help them with the numbness, tingling sensations that they have, especially at night. So it might be, I think it's probably about 50-50. And there's occasionally someone will have neuropathy and then have these symptoms and then come to find out they're an undiagnosed diabetic.
And what about you, Dr. Stouter? How do you think peripheral neuropathy is usually diagnosed? Like what tests are done to the patient, or,
Yeah. Well, I agree with Michelle. I think that the people who know they're diabetic, I think they just most of them let their PCP treat them with medications, or they'll do the workup of a nerve conduction study, things like that. I feel like I get kind of the overflow of patients who either their neuropathy, even if they are diabetic, their neuropathy is so bad that they're just desperate for a second opinion, or like Michelle said, they don't know they're diabetic and help them figure that out. And we order blood work. But the other area I like to rule out, with us being podiatrists, is to rule out biomechanical causes as well. Because I have seen people have, bilateral pinched nerves in their back causing bilateral nerve pain. Also important to rule out structural issues like limb length discrepancies, pinched nerves in the forefeet, things like that. So with us being podiatrists, I do think we have that knowledge to rule out biomechanical causes as well.
when I was in school, we were taught to do our little neurological test. I think most you guys probably do it too. I have a little kit that's all set up in my office, and I drag it out, for a new patient that's complaining of anything that sounds like neuropathy, burning, pain, weakness in muscles, lack of balance or coordination. As soon as I hear any of these symptoms, I drag out my little kit, which is a little paintbrush, and I have a reflex hammer, and I test the reflexes. And I even use my metal alcohol gauze holding cup, because it always feels really cold, to see if the patient can detect temperature changes. And I test for Babinski myself, and and then I do a gait examination. I go in the big hall, and if I see them swooning and touching the wall, I see balance issues. So those are some of the things that I look for diagnostically in my office. And it's true, Michelle, I agree that we frequently get the patient is coming in saying they have neuropathy. They might have had blood tests by the general practitioner, or nerve conduction velocity test, as Dr. Stouter was saying. Or maybe an EMG, which is electromyograph, might have also been performed by a neurologist. So those are, I do my testing. I also just listen for symptoms too, is a good way to tell.
Yeah, and I'll just kind of piggyback on what you're saying, but others, objective findings during the exam is dry skin. So a lot of people, when they're diabetic, they lose that inability to sweat and hydrate their skin. So one of the really quick telltale signs of neuropathy for me is like really dry skin. So that's a really quick visual. And then sometimes when I see that, what I'll do is I'll do the like further workup about that. And for me too, some of the findings are also, there's the objective findings, which you discuss with the gait imbalance and the findings with the loss of protective sensation. But there's also the subjective findings, like, how much they're sleeping or not sleeping. It's hard to measure pins and needles. When someone says they have pins and needle sensation, it's like something we can't really measure. The other thing is, I love when couples come in, the husband and wife comes in, and if the husband's sitting there in the chair, in the exam chair, and the wife's in the corner, and in the patient in the other chair, I look at both of them when I'm talking, because like the patient will answer one way, and then the wife or the spouse will like shoot me a look, so like, oh, I haven't fallen in the last year, and then the wife's in the corner like, yeah, you have, like, so but when you're treating people for neuropathy, the other thing I find is, especially when the couples come in together, is that the patient doesn't necessarily notice improvement first. The spouse notices the improvement first. So the spouse may say, like, yeah, he's not running into the wall anymore, or like his feet don't look so dry, or there's others like subjective findings, or he slept through the night, or he didn't get up during the night. So that's kind of how I know that the treatment's working. I know I'm getting a little off track here, but that's just another way, is that, like I said, about the exam is just part of the subjective, like, asking like these questions about how they're sleeping and, their skin integrity.
I wanted to talk a little bit about the causes of peripheral neuropathy, but before I ask you to, I just wanted to quickly summarize it for the viewer, to say that there are so many different symptoms with peripheral neuropathy. It's actually an umbrella term that means any kind of nerve damage, but there's basically three kinds of nerves. There's sensory, which is feeling, so you could feel pain or burning, or extra pins and needles, as Dr. Kurlansky just said. And then there's motor, which could be muscle weakness or the balance problems. And then there's autonomic nerves, and those are your automatic nerves. They're the ones that control your blood pressure and whatnot. And that's where the dry skin comes in, because the nerves control circulation and other functions. So that's autonomic neuropathy. And patients can have one, two, or all three types of neuropathy. So that's why there's so many different symptoms. But with that in mind, I was wondering if I could ask you guys, like, what you think are the causes, the main causes that you guys see for neuropathy. Dr. Stouter, why don't you begin? What do you think are some of the most common causes that you see?
I do think there's so many causes, and we attribute diabetes as the main one. But that's why the term idiopathic neuropathy came about, because we just don't know what to call it sometimes. And idiopathic means without a known cause. So there are a lot of causes that can come from our environment, because our environment is now affecting our organs in such a bad way. So the main organs that, if they accumulate damage, can contribute to neuropathy would include the thyroid, the pancreas, the liver, the kidneys. So I was going to list real quick the top stressors in our environment that can actually damage those organs and lead to neuropathy. So yeah, the top stressors in our environment, I'm going to list them and how they affect our organs. So number one would be viruses. Number two would be bacteria, such as Lyme disease, which is prevalent in my area. Number three would be fungus or candida. Number four would be parasites like the pork tapeworm. And then the last two would be from our environment, such as, alcohol can cause an alcoholic, you can have neuropathy, or the most common thing I see a lot is mercury in fillings. People with a lot of fillings actually can get high levels of mercury in their blood, and that causes neuropathic symptoms. So those are some of the most common things that, outside of the typical range of diagnoses, that I see.
And Dr. Kurlansky, what do you see in your practice as some of the most
yeah,
common causes?
we have a high prevalence of diabetes, but we also have a high prevalence of cancer here in Maine. So there's a lot of people that have chemotherapy-induced peripheral neuropathy. So, we cure your cancer, but with these really toxic drugs, and then you're left with this like peripheral neuropathy.
Oh, that's true. I see that a lot. For me, and I'll answer my own question myself. I would say that I see mostly type 2 diabetics, and many of them are undiagnosed. I would say that's my most common problem. And then I also see a lot of alcoholic neuropathy, but I'm in Manhattan, so that's a very stressful place. So maybe I see more alcoholism than you guys do. And then I also see a lot of cancer patients who are on chemotherapy. That is really, really common. I would say those are my three most common. Okay, now I'd like to talk about basically the patient comes into you and they're already receiving treatments. So not treatments that you prescribe, but what do you usually see? What kind of medications is the patient on, or what kind of treatments has the patient received before they see you? Dr. Kurlansky, why don't you start?
Yeah, for sure. So normally it'd be like gabapentin or Lyrica. And then sometimes narcotics, but doctors up here are getting away from narcotics for that. Some topicals, some people are buying stuff over the counter and just kind of troubleshooting things themselves. But I think the mainstream doctor would first line is gabapentin. The other things that they might do some vitamin supplementation, but really truly most of them do gabapentin, which is also known as Neurontin. So that's typically what I'll see. Yeah, sometimes some antidepressants too. Then maybe we'll throw in an antidepressant as well.
What do you see most commonly used for peripheral neuropathy? Which antidepressant? Do you know which one you see most commonly? Prozac.
I see fluoxetine a good bit.
Yeah, like Cymbalta is a big one. Yeah, fluoxetine. Not as much, but I think Cymbalta is the big one here too. Yeah.
And it used to be amitriptyline, which is the tricyclic antidepressant. I see that a lot. Not so much anymore. I in New York, I see mostly Wellbutrin used for peripheral neuropathy. What about you, Dr. Stouter? What do they do in Pennsylvania?
Yeah, I mean, that's pretty typical, same treatments, but then I also see patients kind of dabble, and they go to Dr. Google and WebMD, so they're all buying stuff online, such as turmeric, they're buying like B complex, like Michelle said, they're trying to supplement. So patients really are trying, but I think we're in an era now of almost too much knowledge. So it is very hard to just go on the internet and get the right answer. And I think that's where we come into play, is trying to steer people in that right direction and not have them waste their money on unnecessary supplements.
Yeah, and you're hitting upon my next question, which is, podiatry is in the front line for peripheral neuropathy because it's a pain in your foot. So people automatically, they say, I have to go to the foot doctor. I don't know what's wrong with me. And sometimes even the GP will send the patient not really knowing, okay, if the foot hurts, do they have plantar fasciitis or do they have a nerve pain? Let's let the podiatrist figure it out. So now I'd like to talk about treatments that would be specifically used by podiatrists that are, sort of alternative treatments in that sense. Dr. Stouter, why don't you start with some alternative treatments that podiatrists offer a patient with peripheral neuropathy?
Yeah, I'm really big on laser therapy. It can do wonders for not everybody, but I'd say a good percentage of patients can progress well with that. Even prolotherapy or natural forms of injectables. Serapin is an injectable that some people, it's made from the pitcher plant, and some people will use that. Creams, things like that. But the other thing that I really like to stress is talking to the patient about their lifestyle and what they're doing day in, day out, because they might not be admitting to you that they drink alcohol. They might think that they have 2 glasses a night and that has nothing to do with their neuropathy. We don't know. Some people are more sensitive than others. So I think it's good to ask them, where do you work? Are you breathing in fumes every day? What are you eating? Are you exercising? So the other aspect of it is spending that time, that quality time, and asking them all those questions, which with our, a lot of appointments nowadays, unfortunately, you're in and you're out and you don't have enough time to sit and talk to the doctor. So with us being direct care, I think that is so crucial, is that we get to spend that time.
And you mentioned, Dr. Stouter, a little bit about toxins. What would you tell a patient who you suspect has peripheral neuropathy because of toxins? Do you offer any kind of treatment or anything for that patient?
Depending on what the toxin is, because I've seen anything from, we have a lot of farms out here, so well water is contaminated with metals and sprays. So I tell people to get a water filtration system in their house, and believe it or not, that actually can make a huge difference. Or if it's something they're breathing in at work, I'll tell them to get a nebulizer and nebulize glutathione, which is a really powerful antioxidant. So it just depends what it is that they're doing that's contributing to it.
Mm-hmm. And Dr. Kurlansky, what kind of treatments do you offer your patient with peripheral neuropathy?
So yeah, I kind of alluding to what Dr. Stouter was talking about is, trying to find the root cause, in kind of addressing that, especially with lifestyle changes, diet, are you drinking enough water? How are you sleeping? Because your perception of pain is more when you're haven't been sleeping well. So I try to hone in and ask, how well are you sleeping? And patients will often complain about pain at night when they're laying in bed. That's kind of when it hits them and they notice it the most. So I really try to break that, sleep cycle, or impact the sleep cycle so they are sleeping better. And one of the ways I do that is with a topical compound. So a topical compound with many different medications. So an topical anti-inflammatory and like gabapentin topically, lidocaine, local anesthetic. So basically I'm trying to get them to put this on at night and then again in the morning so that they can get through the day and then start to get back into that normal circadian rhythm of sleep.
Mm-hmm. I also do, I like orthotics, believe it or not, for peripheral neuropathy. I like the total contact and the tight grasping into the arch of the orthotic, which makes the patient a better shock absorber, and a little bit of real information going to the brain. This is real sensation versus the, fake sensation of the burning and whatnot. So it's like a proprioception corrector, the orthotic. And it's amazing what can trigger the pain. So I think if you can decrease triggers, so I like to, a big treatment in my office is I give any patient who's having laser therapy, I give them a special moisturizer that has a pain relieving medicine in it, like camphor in it. And I make them put that on every night just to decrease, because even the dry skin feeling can irritate the neuropathy. So I do moisturizers. I like prescription vitamins. I like especially B12.
Yep.
And then I also like socks, supportive socks, I think really help just to increase the circulation. I make the patient walk, go outside just to keep the circulation moving, keep the legs healthy and keep the nerves healthy in the feet. So, and the last thing I wanted to ask you guys, last question is, I really want the viewer to have some sort of take home advice, that they can start using today. What can they do at home by themselves? They know they have peripheral neuropathy. They've been to the doctor. They've been diagnosed. They might be taking a medicine. And basically the idea with peripheral neuropathy, I tell patients, is it's better to have more good days than bad days. I ask you guys, what kind of advice would you give the patient at home to have more good days than bad days? Why don't you start, Dr. Stouter?
Water, water, water. No,
Yeah, no, that's a good one.
I think that's the foundation of everything, is just making sure they're getting enough, not too much water, but I'd say about half your weight in water. Now, if you're 400 pounds, you shouldn't be drinking 200 ounces, but about half your weight in water. So for the average woman, that could be, 70, 80, 90 ounces of water a day. And even that, I think, can help tremendously.
Yeah. And Dr. Kurlansky, what kind of advice would you give someone to help them have a good day?
I like what you're saying. I think having something topically to put on, like even after the laser treatment, or just like the cream I was talking about, because you're forced to touch your feet. Like people ignore their feet. So if you're putting a lotion on, or if someone's putting on it for you, you're getting kind of a twofer out of it. Like you're actually looking at your feet and you're also feeling them. You're kind of getting the biofeedback of your hands on your foot. So like you're getting a little bit of massage. You're getting some proprioception and feedback to the nerves that way too as well. So I think touching and looking at your feet, putting a lotion on, I think helps. I think it helps a lot, and just kind of gets a mental awareness of like, oh, I have feet. Like there's so many people that just put their socks and shoes on and then forget about them. So yeah.
And my answer to my own question would be, make sure you get a good night's sleep. That really helps. Go to bed at 10 o'clock, 10:30. It's not how many hours you sleep. It's more has to do with the circadian rhythm. It's when you sleep. So that's what I would recommend to people. So thank you very much for you two spending time today on this podcast. My final piece of advice for viewers is, if you go to any site, whether it's Mayo Clinic website or the Cleveland Clinic website, and they give 5, rules of what you must do for peripheral neuropathy. One of the things on the list is always visit your podiatrist. Sensation is less. You really have you need a professional eye to look at your feet and make sure you don't have any wounds or infections in the feet that you can't really feel. So make sure that you visit your local podiatrist. Okay, thank you very much, the two of you, for participating.
Thank you so much.
And our next Talking with Pods subject is going to be heel pain, and it's going to be by Dr. Kurlansky. So, and that'll be next month. So, see you guys at the next podcast. Thanks.
All right. Thanks for having us.